Good evening, Dr. Mansi.
Hi, Dr. Disha.
Hello. With your permission, Dr. Vijay, I'll just invite everyone. Good evening, everyone. Thank you for joining us today. And on behalf of AstraZeneca medical team, as well as Ahmedabad Cancer Foundation, I would like to welcome you all. I am Dr. Disha Rambia, Regional Medical Advisor for Women's Cancer for AstraZeneca, and I'll be the moderator for today's session. We have a very informative session ahead of us today evening, which we are thinking of covering the perspectives of HER2-negative early breast cancer management from the aspect of covering the genetic testing as well as the surgical and the medical management of these cancers. Before we start, we kindly request the audience to mute their mics while the session is on, and we will be taking the questions at the end of the session today. With this, may I invite our first speaker for today, Dr. Mansi Vishal. She is a genetic counselor and genetics educator associated with HCG Cancer Center, Ahmedabad, to share with us her perspective on Braca mutation testing in breast cancer and key considerations for genetic counseling. Over to you, ma'am.
Hello, everyone. Good evening. So we'll start with the topic. Dr. Disha, my slides are visible, right?
Yes, they are visible.
Okay, thank you. So the topic is BRCA mutations in breast cancer and key considerations in genetic counseling. So as we all know about BRCA mutations, I'll quickly start because I only have 10 minutes time. So as we know about BRCA mutations, we keep on hearing about it. So what actually it is, we will see today. I think the transition is taking a little time. Yeah. So when we talk about hereditary cancer, 5 to 10% of all the cancers is hereditary. In this picture, you can see that 5 to 10% of the breast cancer is inherited and 15 to 20% is familial, which means it runs in the family, but we are not sure about the right genetic cause of it. And 70 to 80% is always sporadic. So when we talk about central dogma of biology, it goes like this. From DNA, RNA is made, and from RNA, protein is made. And human genome, the human genetic code, consists of 20 to 25,000 genes in total. And BRCA1 and BRCA2 are two of them, actually. So what happens when we talk about that, okay, there is a genetic mutation, this patient has come positive for a genetic mutation. Usually what happens when there is a normal gene, a healthy protein is made from the normal gene. And when a gene is mutated, which means there is a genetic change which has happened in the genetic code, due to that, the protein becomes damaged. And sometimes it is not even made. So the protein is not present to like for the body's survival, and the chances of cancer is increased. That's why hereditary cancer is of such an importance. So hereditary breast cancer, there are so many syndromes, hereditary breast cancer syndromes. You can see all the names here, like Lee-Fromm-Annie, Peutz-Jeghers syndrome, hereditary diffuse gastric cancer syndrome, Cowden syndrome and pancreatic cancer, hereditary pancreatic cancer also. But hereditary breast and ovarian cancer syndrome is the most common, for which BRCA1 and BRCA2 genes are the culprit. And in this HB, so like as in short, we call it HBOC. In HBOC, there is a risk of ovarian cancer along with breast cancer, risk of pancreatic cancer, prostate cancer, as well as melanoma in few of the cases. So here, both the genes are shown, BRCA1 and BRCA2. BRCA1 lies on chromosome number 17 and BRCA2 lies on chromosome number 13. And both of these encode for the proteins which are critically involved in the repair of DNA, double-strand breaks. They mostly cause triple-negative breast cancer. Mostly BRCA1 is causal for triple-negative breast cancers. But yes, in HER2-negative breast cancer, BRCA1 and BRCA2 are more common. And there is increased risk, as I just talked about it, that there is increased risk of ovarian, prostate, fallopian tube, peritoneum cancers, melanoma, and male breast cancer. The inheritance is autosomal dominant in case of HBOC, which means that there is 50% chance that the genetic mutation will get transmitted to the next generation. So let's talk about a case. There is a 32-year-old female who came to us, and the pain was experienced, due to which she came, and she was diagnosed with triple negative breast cancer, which is an aggressive form, and it was a metastatic. This is the small family chart of that patient. She is 32, and her mother also died of triple negative breast cancer at 51 years of age. You can see in the picture that a line is drawn over the circle, which means that the mother is deceased, and the age was 51 when she died. So Dimple lost her mother when she was 26. So she's coming with that trauma to us. These are the genetic counseling considerations, which in a pre-test counseling session, which we actually consider. So first step is the detailed clinical and family history. After I take the detailed family history and the clinical history, these are the three aspects of counseling, which we usually follow and which are the foundations of genetic counseling, we can say. So first is empathy. We all know that we have to be empathetic towards our patients, but in a genetic counseling session, it is even more important, because so if we talk about this patient, Dimple is coming with a trauma, with a history for her mother. So she has seen a cancer in her family already, and she is also suffering from it right now. So empathy towards it. Second is active listening. So we are not actively hearing, we are actively listening here. Because unless I understand the aspects, the emotional aspect, the psychological aspects which she is going through, I won't be able to counsel her. Third is the unconditional positive regard. So to all the problems, maybe it might sound a little unrealistic to me, but I have to show unconditional positive regard towards the patient. And why I need to show all these considerations? Because a patient is usually coming, a patient or a family is coming with the preconceived notions about genetic testing. Sometimes they have different myths about the inheritance patterns, the different genetic mutations, and towards a genetic consultant as well. So a proper rapport needs to be built in the pre-test counseling session, and the counseling needs to be properly done for the expectations of a genetic test. So given her history, I'm going to suggest a genetic test for her, that Braca test needs to be done. And the results might come positive, negative, or a VUS might also come in the report. So after her genetic testing, she came positive for BRCA1. It was a pathogenic variant in BRCA1 gene, and it confirms HBOC. So to this patient, there are different recommendations based on BRCA1 result. So basically, there is recommendations of prophylactic mastectomy. So basically, right now, she has both the options. She can undergo, if the cancer is already metastatic, and if the clinician is deciding that mastectomy needs to be done, then it needs to be done. But sometimes patients have options that they can either go for mastectomy, or they can either go for lumpectomy. So in those cases, we as a genetic counselor provide both the options to the patients and tell them to discuss with their clinicians about the right option for them after this genetic test result. So yes, prophylactic mastectomy is an option for her, either for the affected breast or for both the breasts. Then enhanced screening for cancer, which will include 6 monthly mammogram and breast MRI. For ovarian cancer risk, CA125 will be recommended, and prophylactic risk-reducing salpingo oophorectomy also. And then because we always talk about olaparib here, so yes, olaparib treatment options will also be discussed, but that will be discussed in the post-test counseling sessions mostly, and depending upon the case history. Because I have very less time, so I'll just focus on the genetic counseling aspect. So yes, these are the recommendations which will be given to her in the post-test counseling sessions. So when we talk about genetic counseling, it is defined by the National Society of Genetic Counselors that it is a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So suppose this patient, Dimple, she has a daughter. So right now she is positive. And we have mostly seen that when a female is positive, she is mostly concerned about her daughter, if she has a daughter. You can see in the family chart that she has a daughter. So she was concerned about the daughter more than her. So whatever happened to me happened, but what will happen to my daughter? What is the risk for her? So the counseling will include the post-test counseling about the risk for her daughter, that it is 50%, but right now we cannot test her because only after 18 years of age she can be tested for Braca status. And then this is very important to note here. Most of the patients think that if I am positive, then there is 50% chance of cancer in my daughter. But we emphasize that there is 50% chance of inheritance. So first we need to test your daughter. If she comes positive, then only she will need to undergo the surveillance or the management part of it. So that's the thing. If suppose she had other siblings, then we would also suggest the genetic testing for her siblings, that there is 50% chance in her siblings as well. So just a very quick note of genetic counseling. What is the goal? The goal of genetic counseling is to help the families overall along with the patient. So a genetic counselor actually understand the information, understand the history of the patient, and they present the information in a very simple way to the patient so that they can understand the complicated genetic test results and the implications of it for them and their family members. And based on that, they can actually take their decisions. So like if I don't look at the slide, the summary of the genetic counseling is informed decision making. So whatever the genetic test result is, we set the right expectations. We tell the truth in a proper way, given the psychology of the patient, understand the psychology of the patient, and explain the expectations or implications of genetic testing. If it comes positive or negative, accordingly, they are counseled. And so basically, after they come positive, they can have different aspects. Like this particular female is more concerned about her daughter's future. So that will be basically covered in the post-test counseling session. And about the surgical decisions, she will be informed about the different decisions she can take for her surgeries, and informed decision making will be done with the discussion in the genetic counseling session. So yes, a genetic counselor gathers the family history, calculate risks, and compile the relevant information to make diagnosis, a genetic diagnosis, not the clinical diagnosis, and discuss management options with the patient to help reduce risk for the disease. And usually there are two types of counseling session, pre-test and post-test. So in between, there is a genetic test. Sometimes patients come directly for post-test counseling session when they are positive for Braca 1 or Braca 2. But usually this is the process: pre-test counseling, then genetic test, and then post-test counseling. So these are few points where clinicians can use to refer patients for genetic counseling. So anyone affected with cancer at a young age, less than 50 or at 50, any male affected with breast cancer, more than 2 family members affected with cancer in the family, an individual with 2 or more different types of cancer, such as breast and ovarian in the same person, or colon and uterus in the same person or in the same family. So these are the points through which clinicians can refer cases for genetic counseling. And yes, I'm ending with this notion that prevention is better than cure. So overall, genetic testing is actually helping in early detection of cancer. That is our message always to the patients. And based on that, genetic counseling happens. Thank you. I will invite questions, but I think we can take it later on, as Dr. Disha mentioned earlier.
Dr. Mansi, just one point, if you can just elaborate, probably for the benefit of the audience. It's a very neglected part of oncology. That is what I feel. Genetic counseling and doing a Braca testing. So Braca 1, 2, what do you counsel? Braca 1 guy and a Braca 2 guy. Or do you counsel them the same way?
The counseling will be a little different, but usually whatever it is, so be it BRCA1 or BRCA2, I mostly tell them about both. Because usually patients have this notion, okay, BRCA testing. They actually don't understand why BRCA1, why BRCA2. So mostly I explain both of them, that what is the difference between BRCA1 and BRCA2. Like we know that BRCA1 cancers are more aggressive than BRCA2 cancers, and the age of onset is late in BRCA2 than BRCA1. So BRCA1 cancers are mostly early onset cancers.
I think there is a question in the chat box whether this is a germline mutation or a somatic mutation.
So here when we talk, yes,
Yeah.
sir. So here when we talk about hereditary cancer, we always talk about germline mutations, which is done, the testing is being done from blood sample or the saliva sample. So when we are testing the tumor, it will always be somatic, but yes, here it is germline. Because so just one thing very simple, that because here we are trying to find out those genetic variations which are inherited from either of the parent, from mother or father, that will be present in the germline, which means that will be present in all the cells of the body. Okay. And we can test it through blood or saliva.
So Dr. Mansi, one quick question. Does blood transfusion affect your testing?
So, sorry, I could not hear you, Dr. Abhishek.
A patient comes to you, has been transfused blood recently.
Yeah.
Would you alter your testing?
Yes.
Bracha, because I'm asking you just we see a lot of leukemias and lymphomas, and those guys we generally don't do it. So I had a patient recently. I didn't know what to answer.
Right. So yeah.
As far as the Bracha goes, that was for Bracha. Of course, lymphoma, leukemias, I know what the answer is. We should not do it. HLA typing.
Right. So
could have done saliva testing.
So I was just asking. So that is what I did. But can the blood be taken for germline BRCA if a patient has been transfused?
No. We will wait until a specific time if we want to test from blood, but from the transfused patient, no.
But the RBC and the WBC will have a very short half-life. So after some time, they may all die and they will just regenerate after some time. Anyway, I think we can move on to the next topic, and then we can take the questions in the chat box later. Disha, you want to introduce the next speaker?
Yes, sure. Thank you, Dr. Mansi, for a very informative session. Next, I would like to invite Dr. D.G. Vijay. He is an oncosurgeon. He's the director as well as breast cancer specialist at HCG Cancer Center, Ahmedabad. And sir, over to you to discuss the risk stratification and surgical implications in early breast cancer patients.
You will be projecting the slides from there?
Yeah, just give me a moment. I'll share my screen. Just confirm if my screen is visible.
Could you make it full screen?
Yes, sir. Yeah, over to you, sir.
Okay. So, do I have control? I don't. It's okay.
You can just tell me when to move.
Yeah, it's okay. It's okay. So this lecture basically talks about, early breast cancers. Also, there is a subset of early breast cancers who also seem to have recurrences, and therefore it's very important to identify, stratify at least early breast cancer patients and identify them if we can. So we can next. We see about 2 million cases of breast cancer across the world every year, accounts for about 12% of all new cancer cases, out of which about 85% of all cases are HER2 negative, and of them are about 73% are hormone receptor positive, which is a damn good thing to have, hormone receptor positive, HER2 negative. But unfortunately, 12% are triple negative, a bad subset. And again, hormone receptor negative, HER2 positive could be about 4%. And about 11% is about hormone receptor positive and HER2 positive, triple positive as we know them. Across the world, this statistics could vary. Breast cancer diagnosis stage 64% early, 24% regional, and 6% metastatic. In our own country, the figure seems to be changing, and in the urban areas, the numbers could match this, but different areas, it could be different. Next. So basically, many early breast cancer, despite the ideal treatment, optimal treatment being delivered to them, they seem to be having recurrences, and some groups are at higher risk. So this slide shows the cumulative incidence of cancer recurrence in primary invasive breast cancer. So the first graph shows that patients who are hormone receptor positive, obviously over a period of about 10 years, have the lowest incidence of cancer recurrence, while those who are HER2 positive or triple negative somehow seem to run a parallel course of cancer recurrences that could range up to 30%, while those who are hormone receptor positive could be anywhere between 10 to 15%. Similarly, those who are loco-regional recurrences, they seem to do well over a longer period of time than those who had distant recurrences. Again, this is a slide of over 10 years. Those who are T1, T2, N0, nearly 90% of them are alive at the end of 10 years. And those who are T3, T4, nearly only 60% of them are alive at the end of 10 years. Again, grade is grade 1, grade 2, grade 3. I do not go into. So what it basically says that depending upon the higher tumor nodal stage, grade, certain histological subtypes, the incidence of distant metastasis is slightly higher versus loco-regional recurrences. And novel treatment options are all the time constantly needing to be evolved to prevent breast cancer recurrences, at least in the patients who are at higher risk. Next. We have also identified several clinical and pathological features which are associated with a higher risk of recurrences. So this is Disha, I think I really like this slide. So if you see stage 1 versus stage 2, the hazard ratio for recurrence is for stage 1, if you say it is 1, then for stage 2, the hazard ratio is 1.83, and the hazard ratio for stage 3 jumps to 4.44. So someone who is in stage 3 has 4 times higher risk of developing a recurrence than someone who is in stage 1. So what Mansi was saying, that it's so very important to diagnose cancer earlier. Similarly, node negative versus N1 1.84, N2 2.5, and again someone with a heavy nodal burden N3 disease has a hazard ratio of 4.41. Someone who gets pathological CR, PAT-CR after NACT has a very low hazard ratio compared to someone who doesn't achieve PAT-CR, especially in a triple negative breast cancer. Ideally, we would expect a PAT-CR in a patient who has NACT in this clinical setting. And if they don't achieve even after NACT, then it's a really poor clinical setting. This is being extensively used in clinical trials. And I recommend some of the postgraduates to go through this particular CPS-EG. It's also there in the NCCN guidelines this time. And the scores are 0 to 4, 6 based. The details are there in the subsequent slides. So anyone with a CPS-EG score of 0 has a 5-year DFS of 91, and a CPS-EG score of 6 has a DFS 0. So the CPS-EG, how to calculate, I think it is there in the subsequent slides, and I do not go into the details of that. Similarly, molecular tests, the most commonly done is Oncotype DX, and when we see high score versus low score, hazard ratio for distant recurrence 5.2, and it has an intermediate group versus low. Obviously, the hazard ratio is around 2.5. Next. So across the entire spectrum of different cohorts, the risk ratio between the lower risk groups versus the higher risk groups the risk hazard ratios are significantly different, and therefore it's very important that we devise novel strategies, molecules, so that we can treat those early breast cancers and improve survivals. Again, coming back to the same thing, the presence of positive nodes increases a patient's recurrence risk. Someone with an N0 node, the distant recurrence is about 22%, compared to somebody who has a heavy nodal burden, 4 to 9 nodes, has a 52% recurrence risk. So despite outcomes with node positive breast cancer being consistently worse than those with node negative disease, there are not currently any targeted treatment. So can we do any better for them? So currently the standard of care remains the standard of care, cutting across all subsets. So we can't add anything for anyone who is worse off. So that is unfortunately the situation. So anyone who has 1 node positive, 3 nodes positive, 9 nodes positive, fairly consistent treatments across all subsets. Similarly, outcomes in triple negative, even according to nodal status, someone with no lymph nodes obviously does much better than someone who has a heavy nodal burden. Next. Failure to achieve a PAT-CR after neoadjuvant chemotherapy increases a patient's risk of recurrence. We obviously know that. So these are the, on the right side, outcomes in hormone receptor HER2 negative patients. So the EFS in the CT-NEO-BC, the Cortazar study, which was quoted in the Lancet. So someone who achieves a PAT-CR has at about 10 years, has an 85% event-free survival. This is the pooled data from about 12 trials. And this is a similar outcome in triple negative breast cancer, according to the PAT-CR status after a neoadjuvant chemotherapy. This is a DFS in a pooled analysis of 7 trials. I think this was the JCO trial, von Minkwitz, and they have a 90%. So it's so gratifying to achieve PAT-CR in triple negative breast cancer, and at about 1,000. So about 8 years, 90% of them have a DFS. Next. Similarly, I think outcomes in triple negative breast cancer patients according to PCR. So that the previous slide was about DFS. Again, coming back to event-free survival in the CT-NEO, again, the Cortazar study quoted for triple negative breast cancer. I think because of shortage of time, I'll skip this particular slide because it basically talks about achieving EFS and DFS in triple negative breast cancer subsequent to PAT-CR after NACT. Next. So this is the slide that I was talking about, CPS and EG. It is being extensively used in clinical trials. It has been devised by the MD Anderson Cancer Center. It provides a more refined prognostic categorization of patients with breast cancer after NACT versus clinical or pathological stage alone. It incorporates pre-treatment clinical stage, pathological stage, estrogen receptor status, and nuclear grade. Next. So this is the feature. So clinical stage 3B and 3C are 2, the rest are 1, and the rest is 0, 0, 0, 1, 1. So you can go and read this particular article. Pathologically, similarly, some of them are 0. As the stage increases, it could be 1, 1, 1, and then 3C is 2. Receptor status positive is 0. Receptor status negative is 1. Nuclear grade 1, 2 is 0. And nuclear grade 3 is 1. So you could, and then based on that, this is an algorithm which you put in all this data and then come up with a score. And if the 5-year distant-free survival based on that score is, 46%, and specific disease-free specific survival could be. So it actually incorporates a lot of clinical stage, post-NSAT, pathological stage, and puts all that data so there is a likelihood that this could come into clinical usage, because MD Anderson has been aggressively following this, but it's at the moment being used for clinical trials only. Next. Patients with higher, I talked about this in a previous slide, patients with higher CPS and EG scores relapse earlier than those with lower scores. So if you see this particular slide on the right side, so basically those with score 6 are at the bottom of the list, 6, 5, 4, 3, 2, 1, and those with a score of 0, clinical stage 0, then good pathological stage, post NACT, hormone receptor positive, they do very well and are alive at the end of 10 years. DFS, disease-free survival, and even breast cancer specific survival, nearly all of them, 95, 99% of them are alive. Extensively used in clinical trials. It can indicate risk of recurrence, but currently not included in the guidelines in the absence of treatment. So what happens is, though it's used in clinical trials, how does it translate into treatment options beyond those which are based on clinical criteria? So currently treatment options are based on clinical criteria alone. So how this will change is still not identified. Next. Molecular tests can also be used. So currently we are all the time wanting to identify patients at higher risk and whether we can add something to their treatment to alter the course of outcome. Identify patients at higher risk and aid treatment selections. So we know that Oncotype DX, Prosigna, Endopredict, MammaPrint. According to Oncotype recurrence score, those who have node negative, 1 to 3 positive, 4 nodes. So those who obviously with a lower recurrence score across all the 3 node negative, 1 to 3 positive nodes, and with 4 positive nodes, with those who have intermediate scores, low scores, I'm sorry for that, will have a much better, lower recurrence score, and those with an intermediate recurrence score will have in the intermediate area, and those with a higher recurrence score will have a much lower disease specific event survival. Similarly, for MammaPrint also the same thing holds true. Those with a MammaPrint low risk score will have a much better survival. Next. Currently being used in clinical practice is the residual cancer burden, which is primary tumor size, percentage of tumor invasive versus in situ, and the lymph node metastasis. Next. So the residual cancer burden was tightly associated with event-free survival. So even for triple negative. So I think for shortage of time, what I basically want to say with this slide is across all for triple negative, HER2 positive, triple positive, hormone receptor, luminal A, PAT-CR and RCB1, they seem to behave similarly, and residual cancer burden 2 and RCB residual cancer burden 3, they seem to behave fairly similar, though RCB3 with a lot of residual cancer burden 3, they seem to perform very, very poorly. But if you see with a little residual cancer burden, you could still get away, at least in the HER2 positive disease, 88, 91, 94, 94. So a little disease here and there at the end of neoadjuvant chemotherapy is okay. But if you have a lot of residual disease, a lot of residual cancer burden, 2 or 3, I think it has a very, very poor event-free survival at 5 years and 10 years. Next. So a lot of early breast cancer also nowadays going for neoadjuvant chemotherapy, and some of them having residual disease. So many of them, we have a lot of potential strategies for them. In some of them, we go, for example, oral chemotherapy like capecitabine, immunotherapy, PARP inhibitors, CDK4 inhibitors. And for HER2, if we have used it in the neoadjuvant setting, then we use TDM1. How do we evaluate residual disease? Interesting concept, circulating tumor DNA, NGS, xenografts, lymphovascular infiltration, tumor infiltrating lymphocytes, Ki67 and gene expression, all of them being used to evaluate residual disease. Next. Basically, this says the same thing, that depending upon the residual RCB 1, 2, and 3 can be classified as minimal, moderate, extensive. Next. RCB calculator. I think you could go to the MD Anderson site and read. It's a very interesting. I think I had discussed in our tumor MDT group. I'm sure the residents will remember that a couple of months back, I was very interested in this particular concept of RCB. Next. So we know that for early disease, sometimes no systemic therapies is required. Microscopic or endocrine therapy alone is sufficient. As the tumor burden increases, we can go for endocrine therapy if the hormone is, if the tumor is endocrine hormone receptor positive. As the size of the tumor increases, she may require adjuvant chemotherapy. With a T2 tumor, a node and the nodal burden increases, she will need neoadjuvant chemotherapy. And a T3 onwards, N3 disease, sometimes it's better to put her into an investigational agent and a clinical, and these patients are certainly at very high risk of recurrence. Next. So these are the patients. Targeting treatment to optimize patient care. Approximately 5 to 35 patients of breast cancer patients harbor a Braca mutation. So estimated prevalence of Braca mutation within unselected breast cancer patients by receptor. So these are the patients who are triple negative. Out of them, 2 of them have germline mutation and 1 has a somatic mutation. So when we say, and a large number of patients are actually hormone receptor positive. So the number of patients with germline mutations are in hormone receptor is higher. There are 4 here, but percentage wise, if you see the number of patients, germline mutation patients in triple negative is higher. That is what we mean to say. So Braca mutations are more prevalent in triple negative breast cancer than hormone receptor breast cancer patients. I think this was one of the questions that Kalyan had asked regarding somatic and germline mutations. So even in hormone receptor HER2 positive, there could be somebody with a germline mutation. Next. So where does this information of knowing whether a patient has a Braca mutation or not? There are 2 specific locations where this information is very useful to us. One, the Braca mutation, if we know, it can impact her surgical decision. I think Dr. Abhishek Kakru will be talking about how it impacts her treatment, medical treatment. If we are giving her neoadjuvant treatment, if we have the information about regarding her Braca test, it can influence her surgical decision. We would have to, of course, tell the patient that it's a more aggressive phenotype than the sporadic disease. Patients with Braca mutations may have a higher risk of recurrence than non-carriers, and surgical decision making. Next. If the patient knows a Braca mutation status known prior to index surgery, nearly 76% of patients would consider a contralateral profile, would undergo a contralateral prophylactic mastectomy. If the Braca mutation status is unknown prior to index surgery, only about 15% of them would undergo a contralateral prophylactic mastectomy. How true this is in India it's very difficult to say. I think the residents will agree that a lot of our patients are reluctant to undergo germline mutation testing, and even if they are positive, might be reluctant to undergo a contralateral prophylactic surgery. And sometimes they do consider a contralateral prophylactic mastectomy, and not many of them would be willing to consider a bilateral reconstruction, though we have the largest experience even in that. But what I want to say at this point of time is that because in India, when we see a patient, young patient of below 50 years, 35 years, 40 years, with breast cancer, offering her contralateral breast prophylactic mastectomy is very challenging, because she already has a very advanced disease on this side, and she's more likely to die and have a recurrence of the index breast cancer than develop a cancer on the contralateral side. So that is playing on our mind, and that is one reason why we hold back from not offering her a contralateral prophylactic mastectomy. Next. So a patient with a Braca mutation, especially an unaffected carrier, as you heard, Mansi has many options: surveillance, therapeutic risk reducing mastectomy, and salpingo-oophorectomy. Next. So there is no significant difference in the rates of immediate breast recurrences for Braca mutation and control. No overall survival difference observed between Braca mutation patients and controls. Next. Patients with the St. Gallen very categorically said that patients, even with Braca mutation carrier patient, Braca mutation patients could be offered breast conservation surgery, and it's not contraindicated in females with Braca mutations. And 5-year, 10-year, 15-year overall survivals are no different. 5-year, 10-year, 15-year ipsilateral recurrences are different, but the overall survivals, as you can see in this particular slide, are no different. Next. Patients with Braca mutation are at a higher risk for contralateral breast cancer. And you may consider, as I told you, whether you want to do, if you have a very early breast cancer in the index breast, you can consider doing a contralateral prophylactic mastectomy on the other side. Next. There are different strategies you can do to prevent a contralateral breast cancer. Next. We heard Mansi talk about that. So 20 to 30% of patients with early breast cancer have a recurrence in the first 10 years of treatment. Once a patient has developed metastatic breast cancer, treatment is available, cure is no longer possible. So we need to have various risk assessment models, risk stratification, and allow optimization of individual treatment decisions, avoiding over-treatment. Patients with a Braca mutation require a treatment plan that targets the underlying biology of their disease, as well as Braca mutation greatly impacts the choice of surgical procedure as well as the medical treatment plan. I think that's my last slide, and thank you very much for a patient listening.
Thank you, sir, for the very insightful presentation. There are comments, but in the interest of time, we will move on to the next session. Before we invite our next speaker, I would like to bring to your notice that we have added Slido poll function at this next session. We request you to kindly help us make this session interactive by logging in through the link posted in the chat box or joining through the QR code provided on the screen.
You can see the slides, right?
Yes, I've shared the link for the poll as well in the chat box.
So I think people who are interested can vote whenever the question comes. I think we had a nice talk from Dr. Vijay about BRCA mutations, and one of the slides was very interesting. So you could see the dramatic difference once the node, more than 3 nodes were positive in the results or the outcomes of breast cancer. The just curve just fell off. So there is a huge, so thank you very much, first of all, for the opportunity. And in the interest of time, I think we'll just go to the talk. As I think we have already made up from the previous lectures, there is an unmet need. Obviously, there is a huge unmet need in cancer as well as in hormone receptor positive breast cancer. And what is the, where there is the role of BRCA mutation? Where is the role? What is the role of PARP inhibitors? And we'll just take a few slides on anything else which is there significant. So what I have done is there are only 3 significant things in my mind which have happened in the past year in HER2 negative. We are sticking to HER2 negative breast cancer and operable early breast cancer. So we are not looking at metastatic breast cancer. We are looking at hormone receptor positive HER2 negative early breast cancer. So one of them is, if I have to just put it right away, one of them is obviously the role of olaparib in the adjuvant setting together with the hormone. Second would be the role of immunotherapy in a TNBC in the neoadjuvant setting to achieve a pathological CR. And last but not the least would be again the role of CDK inhibitors in your hormone receptor positive setting after the surgery and RT and everything has been done. So these are the 3 things basically what have changed from the previous year. And these are the 3 things which are now recommended, and I think we should go through it for the sake of our audience as well as others, for the patients. So this again, we have gone through this in the previous 2 talks also. So there is obviously the breast cancer is the commonest cancer in females. And as Dr. Vijay already told you, there is a huge unmet need. The triple negative, clinically what we see is the triple negative guys, once they are out, they are out. Many times they do fail. The hormone receptor positive tend to live longer, but tend to have late failures. So if we talk about them, majority of them, or quite a few of them, let's say 30% of them do fail in the long term and the cure is not possible. And there is where we are trying to target our present lecture, the hormone receptor positive HER2 negative curable subset. In this subset, what we have found is that there is a BRCA mutation. Obviously, you could see that TNBCs have the highest incidence of BRCA mutations, but the TNBC overall is like 10% of the breast cancer. And can you hear me?
Yes, sir, we can hear.
So something. So as was shown in the previous slides, TNBC have the highest incidence of BRCA mutations, but TNBC as a whole is just 10% of the breast cancer. What is 80% of the breast, 70% of the breast cancer is your hormone receptor positive. The incidence is very low, but then it's a huge pool of patients having a BRCA mutation. So we need to find out average. What we have written down here is 9, but from anywhere from 2 to 12% patients with a hormone receptor positive disease could have a germline BRCA mutation. I don't think we need to go through this slide. I've already told you, and Dr. Vijay has also told you, the treatment of breast cancer has changed in 2 ways. And to keep it short, what I think is TNBCs and HER2 positives need to be offered neoadjuvant chemotherapy before surgery any given day. Rest of them, you might just follow what we were traditionally doing. In early breast cancer, you operate and give adjuvant, and LABC, you give neoadjuvant and operate and give RT. So, but the 2 subsets which have been separated out is TNBC and HER2 positive, where I think it is mandatory that the patient has to be offered the benefit of a neoadjuvant chemotherapy. The only reason being, you could hear the entire lecture from Dr. Vijay. They are focusing on PCR. Not achieving PCR is very important, and so that you can target these patients better for the next level of drugs after the PCR has not been achieved. So that comes to the first question of the poll. If anybody is ready to scan the QR code, according to you, is BRCA mutation status an important consideration for planning the medical management of Indian HER2 negative early breast cancer patients? So it's a tricky question. So I'll just wait for a few seconds if anybody is logging in.
We have very few response, but they're all pointing towards yes, there is an important.
Yes and no, both maybe. So you use the word Indian. I don't know how much people are keen in doing Braca mutation and involving changing the treatment accordingly. So why it is important? I think as I already told you, the hormone receptor positive is the largest pool of breast cancer patients. And although the incidence is low, but that amounts to a large number of patients with hormone receptor positive disease would have a Braca mutation. So and obviously BRCA mutated patients are younger patients, have an aggressive disease and need to be treated differently, both surgically also. You had a nice talk about how surgery has to be different, or counseling has to be different as to what has to be done. And there is a very important thing now, that they need to be treated also a bit differently. So as I just told you, from anywhere, these are registries across the world. People have reported BRCA mutation. Germline, from anywhere from 2% to 12%, 15%. So average, you could put it as anywhere from 5 to 9%. Very little data from India, but whatever we have is, you could see this one of the centers from South where we had about 60 TNBCs patient, and they had out of that about 13.5% of the patients had BRCA mutation. Obviously, TNBCs have a higher proportion of patients with BRCA mutation, but I think you'll get better data in the future, because now we have started performing BRCA mutation practically most of our patients, and the data would be collected. It's become much more affordable and available. I thought this would be taken up by Mansi, but where do you test? Simply putting it is, any young patient, she told you, need to be tested for a BRCA mutation. Very important addition in this slide. I won't describe everything. Is any age, you need to do a BRCA mutation testing. If you are looking at an HER2 negative hormone receptive breast cancer, who you need to decide on adjuvant olaparib, and even in the metastatic setting for the same case. Triple negative, obviously it is, the incidence is high, so it's a no-brainer. And so these are the two differences which are there from probably from the previous couple of years, that because olaparib is now there in the metastatic and in the adjuvant setting as well as in TNBC, so you need to do it in practically, I would say, except for the HER2 guys. Even in HER2 you might do it, but except if you have to remember it in one line, except for the HER2 guys, we need to do it in every patient. So that comes to the important part of the talk. So what do you do with this BRCA mutation? How do you target it with a PARP inhibitor? So basically, this is the trial, Olympia trial, the phase 3 trial of olaparib in the adjuvant setting in the germline BRCA mutated patients, obviously who are HER2 negative and early breast cancer. So patients with germline BRCA mutated, BRCA 1, 2, stage 2 and 3, obviously HER2 negative. They could be hormone receptor positive or they could be triple negative. There were two groups. One is the neoadjuvant group, who received this entire neoadjuvant chemotherapy. If it was a TNBC, the criteria for using a BRCA inhibitor was lack of PCR. If it was a hormone receptor positive, again, it was the criteria for using olaparib was a no PCR. And that is where Dr. Vijay was telling you about CPS, that score developed by Andy Anderson. So this was used in this particular trial to put patients on olaparib. So if we have to use this clinical data in our current practice, we will have to start using this score in our hormone receptor positive patients who did not achieve a PCR, because what is recommended is a 3 or more is considered to be high risk, as he had already shown you. And in those cases, basically olaparib was given to patients who were high risk, or high risk meaning those who did not achieve a PCR to a neoadjuvant chemotherapy, or high risk meant even if the patient had received an adjuvant chemotherapy, your larger tumors, your node positive tumors. As he had already showed you in one of the slides, a node positive guy had a poor response, and more than 4 lymph nodes guys had a poor response. So clinically high risk or pathologically high risk guys, you need to give olaparib in the adjuvant setting, and they were randomized to olaparib compared to your placebo for 1 year, 300 milligram BID. And what were the results? This we have already seen, so I won't go through it again. So this was the invasive disease-free survival, or the IDFS curve. What is important is, at the end of 3 years, this was the previous data, it reduced the risk of invasive recurrence, the risk of death from invasive recurrence by about 42%. You can see the curves are self-explanatory. There is a difference of more than 8%. HR was significant, so HR was 0.58. That means 40% patients were prevented from recurrence. Again, if you see the distant recurrence-free survival, the HR is 0.57. So about at least 40% of the patients had lesser chance of distant recurrence and death. And the difference is about 7.1%. So statistically significant. And if these are the updated data which AstraZeneca has provided us, the 4-year and in both of the cases, the IDFS and the different distant recurrence-free survival, in both the graphs, you can see the difference has been maintained even at 4 years. So roughly around 40%. So the difference has still been maintained. And what they have concluded, longer follow-up confirms that the distant free recurrence survival benefit in adjuvant olaparib versus placebo was there, with over 7% more patients being alive or being free from distant recurrence at 4 years. So good enough. I think it was a good improvement. And as far as the overall survival goes, this is the last 4-year update we have. There is a difference of about 4%, roughly around 4%, even in the overall survival at the end of, let's say, around 4.5 years. And you can see again, it is statistically, the HR was 0.68. So it was significant. So difference of 4% in the overall survival as well. So what the question remains, again, you have a good drug which needs to be used in your patients in high risk cases, even in the adjuvant setting. But there is always a concern. The critics might say, what about the side effects? So olaparib is no ice cream to take. It has its own problems. You can see from the right hand side that you have nausea, you have fatigue, you have anemia, you have vomiting, headache, diarrhea. Those who have used olaparib in ovarian cancer would know that hematological toxicities and GI disturbances is a problem. But what was good was that the incidence of MDS ANML, which is very concerning as a part of side effect for olaparib, was negligible, practically negligible. And serious AEs were very minimal compared to placebo. So you had a few side effects, but not very critical. Again, these are a few graphs which they have presented in the form of quality of life being affected by the olaparib. We are talking about adjuvant setting, so it has to be very carefully balanced with the side effect. Although there were side effects more than in the olaparib arm, which is quite expected, but they were manageable, and probably they declined immediately. That is the graph what is trying to tell you. They declined once the 1-year period of treatment period was over. So it did not affect the quality of life over a long period of time. So adjustable, as I would put it. So it's the same remains for diarrhea and vomiting. You can see from the pink bar that definitely the side effect profile had increased, but once the drug had stopped, you can see it was back to normal. So it did not last long. It was not that the patient had to suffer a long period of time, and it was adjustable. So basically what we are trying to say is that it's a useful medicine in the adjuvant setting, and I'll come to my last slide later on, where it has been already approved in the adjuvant setting in high risk hormone receptor positive patients. A word about this study, brightness study. So this was another study, again TNBC, new adjuvant setting. So in this case, what they did is use paclitaxel in the neoadjuvant setting in TNBC patients, operable TNBC patients. And in one of the arms, it was paclitaxel. Other arm, it was paclitaxel with carboplatin. And the third arm, it was paclitaxel carboplatin with another of the PARP inhibitors, vilaparib. Interesting thing is that what happened is that definitely you can see from the bars that the two arms, the PCR, about 53 and 58%. These were the paclitaxel carboplatin arm, and the second arm was paclitaxel carboplatin and vilaparib. The paclitaxel alone arm had a PCR of just 31%. So definitely your carboplatin, which is what I call poor man's PARP inhibitor, did work better than just paclitaxel itself. And you can see from the graphs which have been separated, the green and the red one are the ones with vilaparib and carboplatin, and the blue is your just paclitaxel. So what was important to note that carbo did as well as vilaparib, and vilaparib did not add much to the PCR rates, EFS and OS. At least it was not statistically significant. Numerically, it might look about 5% difference, but it was not statistically significant. So the interesting data which we had in the last 1 year is that some of the trials are positive, some of the trials are negative, but then we have landed up with approvals in our clinical setting, which we need to remember and use them judiciously. So what are the other improvements we had? So this was one, I told you, adjuvant olaparib. The other is, of course, the approval of pembrolizumab. This was based on Keynote 522. Pembro was approved in the new adjuvant setting in TNBCs. And so this is the trial where you can clearly see the green bar is your Pembro arm, the brown arm is your traditional chemo arm, and the difference in the PCR is of roughly around 14%, which was statistically significant, as well as the event-free survival. There was a difference of about roughly 6%, more than 6%, about 7.5% in the EFS as well. So based on the and the effect, you can see from the graphs as well, it just crossing the line of unity in all subsets. It was pre, post menopausal, stage 2, stage 3, hormone receptor positive also, sorry, node positive, node negative. In all of them, it was favoring your chemo with pembro arm. So in this case, it was paclitaxel carboplatin together with pembrolizumab, and pembro was given post surgery also in the form of maintenance for about 9 cycles. So this is your Keynote 922, where, sorry, 522, where pembro was approved. It's not moving. Pembro was approved, and pembro is now in the NCCN recommendations, obviously in your TNBCs, not only in the new adjuvant setting, obviously in the high risk category T2 and more, but it is there in the adjuvant setting as well, or in the patients who did not achieve PCR. So even in this trial, just like the previous olaparib trial, it was either not achieving a PCR, which was considered to be high risk, where pembro was approved, where pembro was used, or clinically high risk cases where new adjuvant pembro was given, a large tumor or a node positive disease. This was the other trial. So just to go briefly on this trial, the IM Passion 031. So this was your Tecentriq together with chemotherapy in the new adjuvant setting. You can see the PCR rates irrespective of the PDL1. Even in the PDL negative guys, the PCR improved by 13%. So PCR was definitely improving by more than 15%. But what was important is that the overall survival in this trial did not improve a lot. So the overall survival was a problem in this trial. We did not have a overall survival advantage. So probably what I remember last is Roche has withdrawn this drug from triple negative subset, although the PCR rates were very high. The only drug so far we have is pembrolizumab in the new adjuvant or the adjuvant setting in the TNBC. So that comes to the last part of my talk, and make it short, is the Monarch E trial, which is your adjuvant abemaciclib in your hormone receptor positive cases. Again, the theme remains the same: high risk node positive guys. So high risk in this case were a few subsets. So high risk was either a patient having a tumor of more than 5 centimeters, or a Ki67 of more than 20%, or a node positive guy. So just as we had seen in the previous lectures, node positivity dramatically reduces your outcomes. Your large tumors dramatically reduces your outcomes, as well as he had already told you, the lack of PCRs. But in this case, what they did is high risk guys, after your traditional chemo surgery, were put on 2 years of abemaciclib, and obviously in the IDFS as well as the distant recurrence free survival, although small, the magnitude of benefit was small, but it was statistically significant. What they concluded is that there was a 30% reduction in both invasive disease-free survival and distant recurrence-free survival in the abemaciclib arm compared to your traditional endocrine therapy in these high-risk subsets, not every case. And over a period of time, again, the IDFS benefit or the benefit was maintained. So what they concluded is, you can see from the last part of it, there is a 30% reduction in the risk of developing invasive disease-free events. Absolute difference between the two arms is about 5.5% at 3 years, and that difference has been maintained in the high-risk guys. Again, it has to be carefully balanced with the problems that abemaciclib has. So you should remember that these are not easy drugs. These are all targeted therapies, but then they have their own problems. Although abemaciclib is considered to be a good one amongst them, but then it had its own problems. So you can see from the pink bars, the incidence of cytopenias, diarrhea, fatigue was more than your traditional. Obviously, traditional endocrine therapy has a very little side effects, but again, what was said is I'll go to the next slide and then I'll show you what happened. So the other two drugs in this category, if we are very familiar with them, that is the palbociclib, which came first, and the ribociclib. The trials with both of these drugs, so this is the palbo's adjuvant trial in the same subset of patients. It did not do anything. So there is zero difference between the two arms at overall as well as disease-free survival. And this is the other one, the Pallas trial. Again, you can see it's bang flat. There's no difference between the two arms. But there has been criticism to this trial. There is a lot of criticism to this trial that there was a lot of discontinuation of the treatment. Another problem with palbociclib is that it is given 3 weeks on, 1 week off, whereas abemaciclib is dosed continuously. So that was one criticism. The other criticism with a lot of discontinuations, lot of adverse events. At least 40% of the patient had discontinued the palbociclib in the adjuvant setting due to side effects. So that led to a lack of efficacy in both of these trials. So at least that is what the criticism is. And abemaciclib being a more selective CDK inhibitor, so it works more on CDK4 and less on the other bystanders, and leading to less side effects and more continuation of the drug. So that is where the advantage was pulled off. But as I just told you, these are three important changes which we have in our early breast cancer adjuvant settings or neoadjuvant settings, but they have their own fallacies or their own criticisms as well, although they have made themselves into the guideline recommendations. So you have to use them clearly, discussing it with your patients, discussing about the side effects, because we are looking at patients in the adjuvant or in the new adjuvant setting where it's not very easy. It could be very easy in the metastatic setting. A quick one slide. So this is interesting data which I think it has come up since last 3-4 years, where it was clearly found out that cell cycle inhibitors or your CDK inhibitors were actually doing worse in patients with germline Braca mutation. So you can see the first graph is your OS in germline Braca patients with first line therapy of CDK4/6. And in this, the purple line, the lowest line, the purple line is the patients with germline Braca mutation. The other two guys are without mutation. And again, the second graph is OS in germline Braca. In the second line CDK use, the purple line is doing worse. In all the three, you can see this first line, second line, and third line and beyond. The cell cycle inhibitors were doing worse in patients who were germline Braca mutated. So there are reasons, there are hypotheses, there is clear description on why this is happening in germline Braca mutated patients. Important thing to remember is why I put this slide is that you should, even in the metastatic setting, probably we need to do germline Braca before just jumping onto CDK inhibitors in our patients. Although there is still, we are awaiting large data or phase 3 data for this, but then there is clearly evidence that germline Braca mutated patients have poorer results to your cell cycle inhibitors. So you have to be careful before using them, maybe in the adjuvant as well as in the metastatic setting. So I think that is where we conclude. There are a couple of slides. One is a polling question. According to you, which factors now, after hearing all of this, would be relevant consideration of medical management of Indian HER2 negative early breast cancer patients? So maybe if somebody is there, you can vote. So you heard everything about Braca. You have heard about from Dr. Vijay's case about non-PCR, nodal involvement, tumor burden, your importance of CPS. Obviously, genomic signatures will get more in the future. We have few in the adjuvant setting. So you could answer, you could just poll.
Unfortunately, we don't have any responses to that.
So if I have to conclude, this is the conclusion slide that you had put up. If I had to conclude, probably this is my conclusion slide, and you could see hormone receptor positive guys, high risk, no PCR. You can see adjuvant endocrine therapy category 1 obviously, and adjuvant olaparib if germline Braca mutated. And of course, your CPS score is greater than equal to 3, or there is a no PCR, there is a residual disease. And the last part of it is, we are not discussing about HER2 positive. The last point part of it is your triple negative guys. So triple negative guys, again, if you have not achieved a PCR and you are Braca mutated, obviously you should be receiving an olaparib for 1 year. you could receive a pembrolizumab if you had given that preoperatively, and you could use it in the neoadjuvant setting, pembrolizumab, if you are a high risk guy. So I think important modifications to treatment which have happened, I think, since this January only, because what I remember is this January only all these have entered into the NCCN. It was not there in the previous NCCN, and these are important changes which have happened. You could very well see the dichotomy that few trials positive, few trials negative. It is there are the problem of side effects. There is a problem of balancing your improvement in the survival versus the side effects. So it has to be done obviously in consultation with the patient. That is what I would end this talk with. Thank you.
Thank you so much, sir, for the very comprehensive description on the changing landscape for HER2-negative disease. We have overshot time, but there has been one question in the chat box. Does PARP inhibitor is available in generic form also?
I won't say it is generic, but you have rucaparib from Zydus, but I don't think there is data to support rucaparib in any of these except for ovary. So I think breast olaparib is the one which is approved. I wouldn't say it's a generic, but I don't think it is recommended to use it because I don't think they have data for breast cancer. The only data they have is for prostate and ovary. I think they don't have any trials or any data for breast cancer as if today. Maybe I need to find out. So for breast cancer, you need to rely on olaparib.
Thank you, sir, for the answer. Any other questions from the audience? Dr. Vijay, any comments from your end?
No comments. Thank you.
If there are no questions, then we can close the session for today.
Oh, yes. Abhishek, any questions?
No, sir. So I was supposed to ask the questions.
So please go on.
No. So the only question I add is that I think Dr. Vijay answered it, that you have a lot of problems explaining people as to go for a prophylactic mastectomy. I think useful tip that he gave, because patients come so advanced, so maybe you can postpone that entire subject for a later time, because once you see a germline Braca mutation, your mind tries thinking in several different directions, and probably you jump into the discussion which probably can be done at a later stage. Because so many patients come with an advanced stage. Early stage guy, maybe he is the candidate for counseling and early maybe doing whatever is recommended in the risk reduction part of it. And an advanced case, maybe you can just wait for him to fare well and then jump into it. Because what happens is once you see a germline Braca, you tend to just then move in all directions as to what has to be done. And that creates a lot of chaos.
One follow-up question actually regarding Braca mutation testing. So would you recommend that we need to rethink the testing criteria, or when should we test for the Braca mutation?
So if you go by what is coming up, probably you should be doing it in every patient. That is what I feel on day one. Because how do you decide on whatever needs to be done? So you need to decide on new adjuvant, you need to decide on adjuvant olaparib. In a metastatic setting also, now you need to decide on germline Braca, because we are very fond of using a ribociclib and a palbociclib, but there is data to contract that also. So probably except for HER2, where its incidence seems to be really low, I feel most patients need to be tested for Braca. Maybe an elderly chap, you could postpone it. I don't know. You couldn't do that also, because suppose it's an adjuvant case, you would have to do it. Unless proved otherwise, you need to tell him that you are a candidate for a olaparib in the adjuvant setting. It's a different thing whether they take it or not due to the cost constraint, but we need to tell them.
I did want to ask Dr. Vijay if he has any experience with somatic Braca mutation testing. So is there any data suggesting that somatic Bracha mutation testing, like for breast cancer?
No, we haven't had any experience with somatic testing for.
Sir is already there in his garden.
Just reached home.
Apologies, we extended the time a little bit, but it was a great discussion. I think.
Let me ask you, because they have done the trial only in Germline Braca. Obviously, they must have samples. They must have evaluated patients who had responded to even somatic mutations, guys. So just like ovary and the other recommendation, any data from AstraZeneca?
So at this point in time, for the Olympia study, we don't have data on the somatic Bracha mutation testing. But there are a couple of other studies for the metastatic setting where they have looked at somatic Bracha mutation testing and the response to olaparib. And similar to the PALB2 mutation, even somatic Bracha mutation has shown like an overall response rate of 50%. So from that results, there have been data. However, we don't have anything in the early breast cancer setting. But the recent ABC6 consensus also did mention that, even though there is very less data, you can consider these patients with somatic Bracha mutation as well as PALB2 for candidates for PARP inhibitor therapy. So until now, we don't have. Yes, Dr. Mansi.
Yeah, I have one question to Dr. Abhishek and Dr. Vijay also. Like till now, like so many patients you must have tested and you have observed the status of BRCA1 and BRCA2. Have you observed BRCA1 or 2 mutations in the older patients, like beyond 60 years of age?
No, but if they have not been part of the guideline to test beyond 60 years of age, I don't think we would have tested them. I think our cutoff till recently was 50. Okay. So we have still stuck to age of about 50, not gone beyond that.
Yeah, so like for triple negative breast cancers, it was 60.
I know. For triple negative breast cancer, the age limit has been extended to 60. So we would need to be that is exactly what Abhishek was telling in the previous this thing. So now testing for BRCA, it opens up a whole new vista of new treatment options. So how it impacts her surgical options, her medical options, and whether she's ready for all of that. So, and see, what do you do with that information?
Yeah.
So that is also
tell them to take an olaparib if we can afford. So I think now think age goes out of the window now.
That is exactly what she wants us to test. So 60 practically covers everyone. So
yes,
if you have a patient, even if she's 60 and she is a high risk, which is very common to have. In 60, correct, you have 90% ER positive and a T2 N3 so many times. So those guys are candidates for an olaparib. So you practically need to test everybody. Most of the elderly females come with very advanced disease because they don't tend to come out at least after a year. They come out only after a year or so.
That's true. But theoretically speaking, we don't expect BRCA beyond 60 actually, because we were always taught that, okay, for hereditary breast cancer screening, for especially BRCA, beyond 60, we don't need to go. Because mostly these cases are like
Disha can
less
tell
than
us,
60.
So how many patients over 60 are BRCA positive in your trial?
Yes.
So about
hello, sir. Sir, can I ask one question?
Yes, please go on.
Suppose a young female patient with ovarian cancer and on which somatic BRCA came positive.
Hello.
Somatic BRCA test. So on the basis of somatic BRCA test, can we go ahead with bilateral prophylactic mastectomy, or we have to confirm a germline testing for first? Operated ovarian cancer patient for which we did a somatic BRCA that came positive. So before going for breast prophylactic mastectomy, whether it is necessary to do germline first, or can we go ahead with a surgery on the basis of somatic test only?
See,
Mansi, if she has a somatic testing, is she certainly going to have a germline mutation as well?
No, sir. So are you asking that she is
was
positive on the tumor sample of the ovary, right? Somatic BRCA is positive on tumor sample of ovary. So yeah, it needs to be confirmed in germline, because it is positive. So the tumor sample is positive for BRCA does not mean that she is having germline BRCA mutation. So
that's why I'm asking.
So hereditary means it has to be germline, and if it is hereditary, then only you can cut somebody's organs. No? You cannot cut somebody's organs
that's
just
why I'm
because
asking.
you had a tumor BRCA. Tumor BRCA, if you start testing every tumor tomorrow morning, at least 10% of all tumors will turn out to be BRCA positive.
Yeah, that's true.
Abhishek, Kalyan is one of our brightest DNB residents. And he's fond of asking such very bright questions. So
good, no, sir. You should ask, because these are very tricky questions. Even it took me a long time to figure out all these
what
questions.
he was asking.
Very, very complicated. Even in ovary, it is very complicated. Yes.
So that's why I'm asking regarding the generic molecule available for PARP inhibitor, because we know there are a lot of costs.
Unfortunately, how do you use a generic, whatever, generic or so-called any other BRCA inhibitor in a different indication where there is absolutely no data available? I don't think you could do that. Because we are not looking at, you are looking at, first of all, adjuvant patients. Metastatic, you might still do an experiment with the patient. That is also not nice to do. But then in adjuvant setting, it is very difficult to do something like this when you know that it's a difficult drug to handle, and plus somebody will just come up with the thought that this is never recommended. How did you give it? So if it has to be done in the adjuvant setting, I think you will have to go to olaparib. I don't know how many patients in the adjuvant setting will actually afford it. It's difficult because they need to make it much more cost effective for people to take it for such a long time and bear the side effects as well.
Thank you.
Are there any more questions? We would be glad to hear any feedback as well for the session.
Disha, you were going to give the answer of Dr. Abhishek's question about
how many patients were more than 60 years of age.
Yeah.
For the Olympia trial, we don't have that kind of information, but surely there were some of the patients that were above the age of 60. I can definitely get back to you if I have a concrete information on that.
Yeah, thank you.
Thank you so much, everyone, for joining. Thank you for Ahmedabad Cancer Foundation for giving us this opportunity to collaborate with you. It has been an interesting discussion. And thank you to our speakers today, Dr. Vijay, Dr. Mansi, Dr. Abhishek as well, and the audience for a very active participation throughout. And any comments from any one of you before we close?
We must thank you for having prepared these slides and taken all the effort and being constantly in touch with us to make sure that the program goes through very smoothly and hand-holding us through this entire process, because very difficult. I mean, so it's olaparib for the surgeons, at least it was a new experience. So nicely conducted and moderated by you. Thank you.
Thank you, sir. We are looking forward to collaborating with you in the future as well. It would be a pleasure to us together.
Ahmedabad Cancer Foundation is your this thing?
Yeah, our this.
Sir, what is it? What is it? I just came to know yesterday only.
So it is like an NGO. We are the trustees for that, and we do a lot of for poor patients trust. So those who can't afford treatment at HCG, we are currently having, so we take their Aadhaar card and other card. This has been there. A lot of the other academic activities are currently educational home also. So it is all the this thing. So that we that it all the donations that come, it is at arm's length. So it's a different NGO. So home, which Kaustubhai did recently.
Yeah, I know.
So it was done through that. So,
Okay.
yeah.
I didn't know that. I thought we had a new association in Ahmedabad.
No. Right then. Bye, sir. Good night.
Bye,
Good night, all
bye,
of you.
bye.
Bye.
Good night.
Good night.
night.
Have a good day.
Thank you.